You're listening to the 40 Fit Radio podcast dedicated to the 40-plus community. Join us as we discuss the truth about fitness and health using science, reason, and the experiences of our host and content experts. Welcome to the 40 Fit Nation.
Hey, welcome back to 40 Fit Radio. This is Coach Trent, and we are going to listen in on the second part of our interview with Dr. Daniel Clearfield. He's a sports medicine doctor and an expert in regenerative therapy, which in the first part of this conversation, which we aired last week, we talked about what regenerative therapy is, Dr. Clearfield's background, and how he got into this stuff. In this episode, we're going to talk more about what exactly regenerative therapy looks like in practice. So he mentioned proliferative therapy, or prolotherapy for short, in the first part. In this episode, Dr. Clearfield is going to talk more about what proliferative therapy actually looks like and what he does with patients on a day-to-day basis, as well as what the rehab model looks like in terms of physical therapy and training after he does a procedure. So I hope you have found this interview interesting, a little different from our normal content. If you want to hear more from Dr. Clearfield or any other expert out there, let us know. Drop a note to us on social media or send us an email at info@40fit.com. In the meantime, let's get to part two.
So let's talk about procedures. You want to talk about specific procedures and how they apply to the public and the treatment population.
Sure. And so prolotherapy was my introduction to it. Prolotherapy, again, proliferative therapy, it's been around for a while, and there's like several different like concoctions that can make up a prolotherapy kind of substance. The most common thing that's been used, and some of the other things have kind of gone out of favor just because of maybe enhanced inflammatory reactions after. So you get like just a little bit too much pain, too much flare-up afterwards. But dextrose prolotherapy is definitely the most widely known. And so dextrose, a sugar, is used at different concentrations, whether you're injecting into soft tissue, such as a ligament or a tendon, or into a joint. And it can help in regards to kickstarting that body's rehabilitative kind of process to be able to help stimulate the body to send the healing factors back to that area. And so with prolotherapy, we were talking about the speed bumps, or not the speed bumps, the potholes in the road. So we have our chronic pothole. And so when I am just doing needling, so a lot of needling is a great technique. A lot of physical therapists are doing dry needling. What I like to say is I do wet needling because I'm using a little bit of a solution so I can, have some anesthetic in there as well. But if I just needle that pothole, so if I just dig up that pothole, maybe it's enough that, that somebody's like, hey, call the city. That pothole's gotten worse over here. And so they're like, oh, so it's like we cause some micro damage to that tissue, trying to help stimulate up that body's natural healing response, seeing that that's going to be enough. If we do prolotherapy, then that's where we definitely get that call into the city, and we ensure that the workers are going to be able to come out to that area and be able to repair that pothole. And so with prolotherapy, that tends to be the response that we're getting with that. With platelet-rich plasma, that's where we're taking the blood from the individual, we're spinning it down, concentrating it to get those concentrated growth factors, and we inject it back into that area. So once again, we're digging up that pothole, but then rather than putting the call into the city, we're putting the city workers directly there. And so it's just a little bit more of a pronounced, more exaggerated type response. And so you get like a more potent response from that when we're doing things such as the stem cell treatments. And so the stem cell treatments that are out there are the bone marrow aspirate concentrate, where we take it from typically the posterior superior iliac spine region in the back of the pelvis, or we can take it from adipose tissue. We can take it from, we do a little bit of a slight liposuction kind of procedure on the abdomen or the flank or the upper thigh or the upper buttock, and we take that tissue. And some people get excited when they hear liposuction. I always say it's like, I am not a cosmetic surgeon.
You could have a dimple there.
Yeah. So while you're at it, though, you know, if you could kind of...
They're like, if it looks better afterwards than placebo effect, that's fantastic. But, we're not taking out a significant amount of tissue to have that much of a change. Yeah. But there's regenerative tissue within that. And so when we're doing the stem cell type treatment, we are digging up that pothole. We are filling it up with the best kind of tissue possible. And then we have those workers right there to be able to kind of work on it. And we also have the mirror there supervising to make sure they get it right. And so again, just a more potent, pronounced kind of response. And so those are my Clearfield analogies on what's kind of going on with the regenerative medicine and what we're doing to try to help heal that tissue afterwards.
Sure. Yeah.
But then another segue from that would be, what do we do afterwards to make sure that we're not reopening that road too soon, to make sure that we're protecting that area as we're allowing it to heal itself, because it's starting out just with that immature baby type tissue. And then we need to allow it to mature into healthy tissue that has the proper integrity to accept those loads that we're going to be putting across it. And maybe at first it can accept a load such as walking, just plain weight bearing, but can it accept jogging? Can it accept higher loads such as weightlifting? And so that's where it's important to make sure that we have the right rehabilitation protocols to be able to get them back. And so that's a huge part of it too. So you could be the best regenerative injection specialist in the country, and if you don't rehabilitate them the right way, then your treatment is not going to take its proper effect. And so that's a very important part of it also. If you just see, and we were talking about like, how do you know that you have the right kind of specialist when you're having this done? If you just see somebody that says, I'm going to do the injection and then just kick you out, to the street, you're good to go, then that's probably not the specialist for you. It's like, what is the aftercare? And that's, there's forecare, what you need to do to prepare for that procedure. There's, what do you do on that day of the procedure? And then there's what you do afterwards. And I always try to make sure that I really have a tight follow up with all my patients to make sure that they are progressing, questions are answered, they need to be reminded. Sometimes they come in on the day of the procedure and they're just so mindful of, I'm going to have this procedure done, that they don't even hear all that other aftercare that I'm really kind of going over with them. And going over with them several times. I usually have to really I have to keep just kind of beating it into them as far as I do it in my consultation with them when we're talking about it. I do it on the day of the procedure. I do it after I'm done with the procedure, and I do it when I follow up with them. And so I have to keep just kind of making sure that they are doing the right things, because people will fall back into bad habits. And so we're trying to make sure that we're doing a little bit of a paradigm in regards to how they act, how they move, how they function, whether it be their sport, whether it be their personal life activity, to make sure that they aren't going to become a chronic patient for me. That's not my goal.
Well, the one thing I notice about your practice, education. I mean, we're empowering our patient base and our consumer population to understand how to better treat themselves. Like you said earlier, the perfect patient is the patient that gets better and never comes back to see you. That's the goal. I want to see them in the grocery store, or out on the soccer field, or out on the golf course, or out doing what they love to do and enjoying life. That's the key. And so all these different procedures that you have can focus to treat at all these different connective tissues and structures. And so for the patient who has, or for the person who has, let's say, knee pain, shoulder pain. Let me give you an example about myself. So I had a left shoulder rotator cuff repair, foreankle repair, and a labral repair, and a Mumford procedure and a subacromial decompression about 3.5 years ago. I knew at the time that my long head of my biceps was kind of beat up, was kind of, just typical scenario of a guy who's done a lot of athletics and has, and what surgeons are doing today, which I do not like as a therapist, is even though that tendon may be intact, they're going ahead and just cutting that tendon off and tenodecing it, which I think is mechanically a bad thing for the shoulder joint, because I do believe that the long head of the bicep tendon is a stronger shoulder depressor than we really know, along with the rotator cuff complex. And so I really like to see that bicep tendon maintain its attachment. So when the surgeon did my surgery, I asked him, I said, if the bicep tendon's beat up, clean it up a little bit. But if it's attached and the labrum looks really good, leave it if you can. And he did. But that's my source of pain now, is that bicep tendon. And so how would you treat something like that? I'm 3.5 years post-op. I do have pain. I still lift. I still do a rehabilitative type program on it sometimes, and I'm very, very active with it. But what would be an example of a procedure that we could do to that tendon potentially and create a better environment for healing and allow that to do better?
Okay. So, first off, what we talked about before, right when you came in, I would see how you move. I would look at how you move. I would look at how you function with that. I would look at what the aggravating kind of motions are that really bother you, because maybe you're moving your arm when you're weightlifting in a way that isn't typical for just everyday kind of activities.
Compensatory movement or something like that too. Yeah.
And I would really try to figure out, okay, what is the big source? What are the other areas that, is there an area that's too tight that needs to be loosened? Is there an area that's weak that needs to be strengthened or stabilized? Do you have the physical ability to be able to strengthen, stabilize that? You have a background so you understand about how to rehabilitate yourself. But at the same time, it's like, I always say, physicians are the worst patients.
Oh, we're terrible.
It's like I say, I'm an excellent doctor. I'm a so-so patient, So.
When the doctor shows up in your office, you're like, oh no, not another doctor to treat.
Yeah, it's always
it's hard.
It's hard for me to listen to my own advice. Sometimes I'm like, I have to pat myself on the back. I'm like, hey, you actually listened to your advice today, right? And
good patient. Yeah,
and we could get away with not listening to our own advice in our 20s and 30s. In our 40s, we need to listen. 40s and beyond, we really need to listen.
Sure.
But that said, so I would look at what are the issues that you're having, what are the dysfunctions, and then what's working well for you, and then are we overworking certain areas? And so I would see if there's a role of physical therapy. I would see if there's a role of osteopathic manipulative treatment to be able to help provide if the joint is slightly out of place, if we're using our kinetic chain improperly, and so we're having neck issues, upper back issues, elbow issues, or anything else within that upper quarter of motion when you're trying to kind of use that shoulder. And so I would look at all those kind of aspects. But then as far as is there a role for regenerative medicine? And so if there is a role for regenerative medicine, do I need to treat just extra articular? Do I need to treat outside the joint? Do I need to treat that biceps tendon? Do I need to come back and restabilize on some of that rotator cuff repair that you had? Is there anything going on within the deltoid? Is there any trigger points that are kind of locked up? But also because of having this issue chronically and we're not supporting our glenohumeral joint, our shoulder joint the proper way, have we developed some irritation just within the joint capsule itself? Do I need to stabilize that joint capsule? Do I need to go in intra-articular and stabilize that? And so I look at all those things so I can really plan it out. And so when I see somebody for a consultation, I always put in my notes, okay, these are the areas that I would need to hit and stabilize. Right. And then when somebody comes in on the day of the procedure, I also just double check any changes, anything I should be aware of, because do I need to kind of go back and just do another evaluation? Every now and then I have the person I do the consultation on, they say, okay, this sounds great. I'm going to go ahead and get it scheduled. And then I don't see them for 3-6 more months. And so if I need to kind of come back in and reevaluate, then
a lot of things can change.
Oh, definitely. Yeah. Did you have a fall? Did you I mean, I imagine that they didn't just walk out, keep their shoulder by their side for 6 months, and then they walked back in. And if they did keep it by their side for 6 months, there's going to be some other stuff to work on.
Right.
What I like hearing is basically this. You're a good diagnostician, and you look at the individual, and you may say to a client like me, a patient like me, hey, I'm not going to inject your tendon. What I really want to do is I want to manipulate your neck and free up some shoulder movement because you've got a tight capsule here, and then give you some rehab exercises to strengthen these other musculature. And boom, the bicep tendon irritation goes away. The bicep tendon irritation is a sign of something else going on in the movement chain or in the kinetic chain or at neck tightness or whatever the other treatment areas are. So it might not just be the shoulder that's the dysfunctional area. It might be some other that's connected within that kinetic chain.
Yeah.
And that's good medicine. That's really good medicine. That's what we need more of, and we have a lot less of today in our medical community, but I think that's really good medicine. And so those kinds of approaches are more novel today than they used to be in the past because a lot of practitioners, number one, they just don't have time to do that, and they don't take the time. Now, one thing people should know about your practice, if they want to use you, is that you're a cash pay only practice. And so you'll give them an invoice or a bill so that they can bill that with their insurance company, but you don't take insurances, correct?
That's correct. Yeah, I say that it's like we don't use their insurance, but they can still use their insurance.
That's right.
And the first reason, because a lot of times people hear that and they immediately go to a negative kind of thing.
No,
but I say it's like I'm doing this model because I want to provide quality care.
Yeah,
sure.
Yeah, it's like I don't want to have that get them in, get them out kind of mentality. And insurance companies, whether you believe it or not, really have an influence on how your physician is practicing,
Absolutely.
How they're treating you, what they're going to be offering you. Is there a tiered system? And so maybe, it's like that first tier is going to be the best treatment for that individual, but maybe I need to go straight to tier 4 because that's going to be the best thing. I always say, what's the quickest sprint to the finish line to be able to get you to that point that you're looking to try to get to? Yep. And I left that system of medicine because I was frustrated with it. And actually, regenerative medicine was a big influence to me me on that. So the regenerative things that we've been talking about, prolotherapy, PRP, stem cell type treatments, this is something that insurance has not been taking care of.
Right.
I remember when PRP for a while in the early 2000s, insurance companies were initially starting to pay for platelet-rich plasma, and reps would come into the doctor's office and they would tell them, this is how you bill for it. And they were billing for like this transplant kind of code. And so doctors that were doing this were getting these insane reimbursements. And so anytime a doctor's happy, an insurance company has to say, let's not make them happy anymore. And so,
let's take their happiness
but at the
away.
same time, it was an improper billing practice, but it was what we were told to kind of do. And so insurance just said, you know what? Oh, no, this is not a transplant. And so what we're going to do is we're going to label this as experimental and no. And so what that's done is it's kind of cut that out of the insurance system. And I don't think that's a bad thing.
Right.
Now, there's some people who definitely take advantage of it. It's like, we're right next door to some areas of Texas here that there's very affluent areas. And so there's people that, there's, providers that will charge, 3 to 5 times the amount that I will charge for these type of procedures. And they don't have individuals that have the knowledge base, understanding, and integrity that I have to be able to do this the right way.
Sure.
And so, it's like, big part of my practice was I want to charge what's a reasonable amount to charge for this, what, covers my time, allows my kids to eat, and keeps my doors open in my practice. But I don't want cost to be the factor of why you're not going to get good care.
Sure.
I want to provide good quality care at an affordable price and practice with integrity. And that's the goal of our practice.
No, and I've seen your facility, and your lab is top notch. Your facilities, your equipment, your staff, very nice facility. It's a really nice environment for healing, and I think the cash pay or the private pay model is a great model. We have 6 practices, and we take insurance, but we also take cash pay at our practice. So if a patient wants to come in and not use their insurance, or they don't have insurance, then we have a cash pay price that they can use for the exam and then for follow-up treatments. And that's one option. Personally, myself, I like to have control over my own health care. I don't have health insurance. I have a medical sharing plan that I use. So I don't even have traditional medical insurance. Even as a medical practitioner, I don't have that.
Oh, same here.
Yeah, I don't want the insurance company dictating what I can do or can't do. And then if I have something catastrophic or major medical, my plan picks it up. And that's really what I want insurance for, those major things.
Yeah. So. And I mean, really, that's what insurance should be for. Just like if you think about it like car insurance, it's like if you need an oil change, do you use your car insurance for that? If you get a flat tire, do you use your car insurance for it? And so at the same time, it's like, what do you use your car insurance for? If your car gets if you need an engine replaced, so it's like if you have heart failure and you need a transplant, if you have a major wreck, and so a major orthopedic surgery, again, a catastrophic type kind of thing, or if a cancer kind of occurs, then that's where insurance is appropriate. But, it's like if your car has a flat tire, you don't use your insurance, but you sure don't want to be driving around on that flat tire. And so we'll get our car repaired like that. But at the same time, it's like if we have a bum knee, a bum shoulder, we'll keep driving around for whatever reason. We just don't treat our bodies the same way that we treat our car. And why should, it's like, it's our body. This is what we have forever.
Sure. Yeah. And one of the things that we do with 40Fit, and as you listen to more of our episodes, you'd see this, Doctor, that we, one of the goals is to shape people's educational mindset on being more holistic about taking control of their own health, taking control of their own fitness, giving them tools, the evidence and the science-based and the content experts like yourself that come in and talk on the podcast, and giving them the tools to be their own practitioner in a lot of ways and avoid a lot of these problems. I stood in your office the other day and we talked about this, let diet be thy medicine. A lot of the things that we do in our daily lifestyles can control our health, our fitness, our function, our capacity, our longevity, our happiness. And our goal is to help to shape that mindset so that people can do that. And that's a lot about what you're talking about. And that's that whole holistic approach to medicine versus just run them in, run them out, give them an NSAID, or, if you have someone that has, that's pre-diabetic, instead of giving them, glucophage or metformin, or, let's talk about dietary changes. Let's talk about exercise. Let's talk about resistance training. Let's educate those individuals. Unfortunately, too, you and I know that some people, that's the hard, and they don't want to do the hard. And so that other modern medical model has to be there for the individuals who really just, in some cases, don't want to do the things that they need to do, too.
Right.
Anything else you'd like to add about regenerative medicine?
So coming back to what you were talking about, the shoulder.
Yes, yeah.
So it's not.
You're supposed to fix my shoulder, doctor.
Yeah.
Fix me.
Yeah. But it's not uncommon that somebody comes in also with an MRI. And sometimes they come in and, their doctor that ordered the MRI or whoever ordered the MRI, you see circles all over it. This is circled. This is circled.
Well, the MRI reports are just...
And then the patient has seen that, and then they've,
They are their MRI now.
Yeah, and then they consult their, Dr. Google. Dr. Google has them worried about this and this and this.
Yeah.
And again, it's like there's so many incidental findings on an MRI. It's like you could take your age after you're 25, put a percentage by it.
Yeah.
And that's how many people, if you just took 100 people that were 30 years old and did an MRI on their back, you would probably
find... It's like DJD of the spine. Well, welcome to the human population, right?
Yeah. It's like, we all have our own little wear and tear. And so MRI is a great tool for being able to characterize tissue, but does that equal wear dysfunction, wear pain, what is bothering that individual? And a lot of physicians chase after MRI findings.
Right.
They say, let's get an MRI. They circle this, they circle that, and then they go after that. And then it has nothing to do with it. And sometimes they have a surgery. Sometimes they have a major surgery. And then sure enough, they're not doing any better. Right. And it was because that wasn't the source of their pain, the source of their dysfunction. Right. And so anytime somebody comes in with an MRI, I will take, I used to just not even look at it. Then I would look at it after. And then they're like, did you look at my MRI? And then I'd say no. And then they'd roll their eyes and they wouldn't hear anything I said. So what I do now is they come in, I take a look at their MRI before I go in, but I stay completely blinded to what that MRI said. I talk to them, I get their history, I do my physical examination, I put my big picture together about what I think is going on with them. And then I think about what the MRI shows and I correlate that. And is there a correlation to what they're describing? And then a lot of times I provide a consultation note to whoever sent them in to me. And I let them know, it's like, hey, this MRI finding that, we had here, because that's what they were sending them to me for.
Right, sure.
But I need to educate them about, I don't think it has anything to do with this based off of this and this. I think it has to do with this right over here. It's like, he's complaining of his bicep tendon, but it was just a trigger point in his trapezius the entire time.
Right.
And so making sure that I'm educating not just the patient, but the referring source also. And so some people are, a lot of orthopedic surgeons, they don't even want to see a patient unless they have an MRI done already.
Right.
So that way they can just look at that and what are they doing with that? So, it's like I would say, again, I've worked with some very good orthopedic surgeons with my old practice. There were some excellent orthopedic surgeons there that practiced with a good evidence base. But then there are some orthopedic surgeons who are just really trying to weed out who can I do surgery on. Right. And sometimes we talk about the nail and the hammer, the surgeon's the hammer and the patient's the nail. All they know how to do is hit that nail. And so all they are looking for is how to operate. And so their spectrum of black and white, is it surgical or is it non-surgical? It's fairly just kind of defined. It's either going to be surgical or non-surgical. And then that gray in between there is very narrow kind of scope. And so they're either, well, there's nothing I can do to try to help you. You just have to deal with this. I'm not you just have to deal with this kind of physician. I always try to partner with the patient and try to figure out what's going on. I know when it is in that point where this is something that you need to talk with a surgeon about to see if this is surgical. But I say it's like, one of the big things I deal with is what I call the gamut of the gray, that in between that black and white. And I'd say I have a pretty large gray zone as far as things that I can do to try to help somebody out, figure out what's kind of going on with them. So if you're coming into me for your shoulder and, hey, I've already tried this and this and this, very often I'm not that first person that you're coming to see. I see a lot of those, we talk about in medicine about horses and zebras. Horses are the common things and the zebras are the uncommon things. And sometimes I have that zebra clinic. And sometimes I have that zebra clinic because I'm able to figure these zebras out. Right. I can identify what it is. Or if I can't identify what it is, I can at least get that zebra or that horse walking down the right path again.
Well, I find that the large majority of our patients are in the gray zone. I don't find that most of our patients are surgical candidates. I mean, and if you look at surgical rates per new patient consult in a surgeon's office, it should be a very small part of their practice. So if you think about that, the large majority of orthopedic patients do not fall in the surgical category. So how do they treat those people? Well, normally they send them to physical therapy or they give them an injection or they give them an NSAID or something like that. But that's really all they have in their bag of tricks to do. In fact, the surgeon themselves have very little actual medicine that they can provide to that patient outside of referring them to another clinician in many cases because they're surgeons. That's what they do. Yeah. So the non-surgical orthopedist or the physiatrist or the sports medicine fellowship trained physician has a lot more, I call it in their bag of tricks. They have a lot more tools in their medicine bag to be able to treat the things that are the majority of the population anyway. And those are those people who don't need to be, quote unquote, fixed with an invasive procedure. And so I find that we have the technology to make things worse.
Yeah.
That we have the surgery technology to make things worse.
You said at the beginning of the episode, do you want the guy who does 10 shoulders a year or 500? Well, maybe you don't want the guy that does 500,
well, in
right?
reverse experience, you want the guy that 500, but you want to make sure that his selection process and surgery, intervention, and outcomes is the key. Yeah. Selecting the right candidate is the key.
And it sounds like one of the big keys and to your practice is that it's patient education. If you're looking for a physician to help you through an issue, are they willing to educate you along the way? And then also, are they investing in your outcome, and asking you to invest in the outcome? It's that equity in what you're doing instead of the one-sided approach where you give an injection and send them on their way. Right?
Well, and
those two things seem to be the key.
That's right. It's a partnership, and I don't have a utopic view about this either. There are some of our patients, myself included, who will live with a certain threshold of discomfort or pain throughout their daily life based on how far they want to push their body.
Yeah.
And there are some, we've talked about my back several times.
Right.
I've had 4 lumbar surgeries. So, I've got 2 rods and 8 screws in my back.
Right.
My back rears its ugly head every now and then. But I also lift, I ride horses, I work cows, I do a lot of stuff on a regular basis. So I'm putting a lot of stress on my back. I'm willing to take the little bit of discomfort that I have because of the quality of lifestyle that I have. So I think that that's important too for us to discuss with our patients, that human existence is not devoid of pain though.
Yeah.
Pain is important for us.
Yeah. I would say
value.
Pain is not a bad guy.
Pain is neutral.
Pain is trying to tell our body something. It's trying to communicate something. Right. And so are we smart enough? I always say our bodies are very intelligent. Sometimes we just have to be smart enough to listen to our body.
right.
And actually follow through. Way. It's like if I was a wrestler, I am beat up from head to toe. It's very rare I see a patient that I have not incurred the same kind of injury.
Yeah, exactly.
It's like right now I'm trying to sit on this stool with, good posture. If I don't sit with good posture, my neck, my back are going to start to hurt.
Yeah.
And so my body's going to say, hey, fire that core. Correct your posture, work on those things. And so your body is going to be able to tell you what you need to kind of do to try to help itself.
Yeah.
I also just wanted to say, because we were talking about, some of that thing. And again, I don't want to dog surgeons, but in regards to, there's a Upton Sinclair quote that I really like to kind of use. That's what I was pulling up here. So it is difficult to get a man to understand something when his salary depends upon his not understanding it. And that's something in the primary care sports medicine field that we bring up a lot, because some of the orthopedic surgeons purposely keep themselves blind to these kind of regenerative treatments, because guess what? We can fix some things that they were going to operate on.
Well, To that being said, evidence-based medicine, EBM, we're now coming up with the fact that do all ACL deficient knees, do all athletes that have an ACL rupture, do they really produce more osteoarthritis than the normal population over time when we don't fix them? If we just do strength training around the joint, stabilize the joint, and they don't have medial compartment instability, let's say, they don't have a meniscus that's gone and a medial collateral that's bagged, but if we have a joint that's reasonably sound otherwise, are the outcomes any worse if we just strengthen the joint? Now what we're finding is they aren't. That patients actually can do just as well at a very high level of athletics just by doing a very aggressive strengthening program many times. We're finding that a lot of surgeries are not necessarily producing better long-term outcomes. They might have better short-term outcomes, but not long-term outcomes. And so that starts us down a road, like you said, to where it's almost approach avoidance by the surgeon to want to even open that mindset, because we are significantly reducing their opportunity unless they have some other skill set that they've developed, like regenerative medicine or in some other non-surgical means. We are reducing their income potential.
Yeah. Nice segue into one thing I wanted to talk about. So I just said I have had a lot of injuries. So I actually, I've torn my ACL, I've torn my MCL, and my medial meniscus, all in the same knee.
Unhappy triad.
Yeah. Yeah, that fun, terrible triad. Now,
Yes.
they weren't all simultaneous. I did the meniscus in college, playing tackle football with my fraternity brothers. And then the MCL and the ACL I did simultaneously, ironically, at my sports medicine conference, playing football on the beach.
Oh, no.
And so... And again, just, myself being a wrestler, fight through the pain and everything. I remember I, heard the pop in my knee, and my knee swelled up. We had just started playing football for like the last 15 minutes. And we were on the beach in Florida, and it was like, oh, and so I just, I was like, oh, you want that knee swelling here kind of stabilized. I played football for 2 more hours after that.
Yeah.
And then the next day, oh my gosh, my knee was just gigantic. But that said, did I have some slight instability? I felt uncomfortable cutting. I felt uncomfortable just kind of stepping off curbs and things. I was told by 2 different surgeons that I did need to have surgery on my knee. But at the same time, I had just terrible insurance at the time. I had a crazy high deductible, so I was going to be responsible for $5,000. Sure. And then I was introduced to prolotherapy right around the same time. I actually had 2 prolotherapy procedures done on my knee. And, knock on wood, I have not had any instability, any type of issue since then.
And you're reasonably strong and fit still. I mean, you train. I can tell you train, you lift, and so.
Oh yeah, I do. Yeah, I do.
Yeah.
I do tough mutters and run marathons and do all those. Well, I need to run a marathon. I've done half marathons, but I this knee actually doesn't bother me at all. And at the same time, I've worked on the things that we talked about, building up that strength, building up that stability. Another thing I did want to talk about that we were talking about in regards to the surgical kind of means, a lot of people, sometimes when they develop some arthritis, they will go in for arthroscopic washouts. They will go in for these little debridement cleanups in the knee. About 5 to 6 years ago, the American Academy of Orthopedic Surgeons, AAOS, came out with a position statement kind of saying we shouldn't be saying that we shouldn't be doing these procedures anymore because they ultimately led to a more rapid degeneration of the knee and more likelihood of needing a knee replacement. And so what we were talking about as far as sometimes it makes it feel better temporarily. So another silly Clearfield analogy that I have for this is if I have a desk, and this is my desk at work right now. And so I know it's messy. If you look at it, you're like, oh my gosh, it's messy. But it's like, I know I have this over here. I know this paper is over here. I know where everything is. And so I sit down at that desk, and even though it doesn't look great, it's functional for me.
Right.
And so a lot of times what the orthopedic surgeons would do, and I saw this when I was on my orthopedic surgeon rotations through my training, is they'll go in there for that goal of maybe cleaning up that meniscus, but then they're like, oh, look at this scar tissue over here. Look at this. They come in and they see that mess and they start cleaning it up. And so if, I have my desk and I know where everything is, and then my wife comes in and says, this is terrible, and she just puts everything away in drawers. I don't even know, throw some papers away. At first I sit down at that desk and I'm like, hey, this is kind of nice. My desk is, it looks nice. And, I feel like I'm productive here. But then all of a sudden I'm like, hey, where's my paper on this? Where's my pen? Where's my, and all of a sudden I just collapse because I don't have any of those supportive structures that my body has naturally made. Again, I'm going to cite the same principle. The body is capable of self-healing, self-regulation, health maintenance. Sometimes all those different little things that happen, that occur in the body in response to an injury, such as an ACL tear that happen in response to like a meniscal injury, sometimes that is the body's natural means of trying to stabilize itself. And when a surgeon goes in there and they just clean up everything, a lot of times they'll show you, here's what it looked like before, here's what it looked like after. And so they clean up that desk. It looks nice. And so at first the patient's doing great, but then you talk about 3 months, 6 months, 2 years later, where's that patient? They're needing a total knee replacement because they've lost all their stabilization means and they've just gone downhill really quick. And the surgeon's like, well, I'm not just going to keep going in there and cleaning it out.
Right.
And ethical-based surgeon will avoid those kind of surgeries now because they know it's just going to accelerate that need for the joint replacement. But, an even more elevated surgeon would say, is there a role for regenerative medicine?
Right.
I do have some orthopedic surgeon colleagues who are recognizing this and trying to kind of avoid that. But at the same time, joint surgeons can make a lot of money off of these, procedures. And I'm not saying that they're only seeing dollars, but at the same time, sometimes they're working for a company that's only seeing dollars. And so they're kind of trying to push their hand in regards to that direction.
I think it's so interesting, because you said a second ago that, pain is not a bad guy. It's not necessarily a bad thing. I was thinking about compensatory movement, right? If your movement pattern adapts to essentially compensate for tissue damage or structural problems, that may not necessarily be a bad thing, as you're saying, right? So if there's tissue that you've learned to adapt for or compensate for with your movement, absent of symptoms, maybe not such a bad thing, right?
Yeah. Well, I think humans love, you have patients come in and say, well, look, that side looks different. I said,
right.
Yeah, humans are not symmetrical. First of all, we're not symmetrical. Yeah. Everything's not the same, right versus left and front to back and superior to inferior. And so there is some you would say, anomalies or difference there, variance there. But I think that what I find in the physical therapy and surgical world is basically this, is that there's this approach avoidance model. There's this physicians are needing to make a living, and so are physical therapists. There are many patients, as I have, this is my 31st year to practice. So as I get more and more experience within the field of therapy, the more and more simplistic my approach is to the patient population.
Right.
The more and more simplistic it is, the less I need to see a patient, because I don't believe the hype. I use some of these terms. These are called Darrenisms or Coach D-isms. They're things like we try to complicate to validate things sometimes. We try to make it really complicated and have all these complicated algorithms to validate our need to the consumer, our need in the mind of the consumer to need us, to provide that special aspect of care. And my experience has been the same as yours, doctor, that the self-healing aspect of the body is amazing. And our job as medical practitioners is to provide that intervention which gets a person's body to heal itself and to do what it needs to do. What amazes me about the human population is they know more about this iPhone than they do about their body.
Right. Yeah.
They know more of the options and the things and the buttons to do with this phone than they do their body. But at the same time, I do not see myself, and I had this discussion with an intern the other day in one of our practices, and he's a UNT intern, and he said, well, we're not healers, we're educators. And I said, I disagree. We're both. I'm a healer and an educator, and I might use education as part of my healing. But I also have a skill level and an interaction with the patient, the use of my hands, my eyes, my diagnostic mind to be able to help them in this process. So I do see myself, it's not mystical, it's very logical, but I am also a healer and an educator. I'm not just an educator. Would you agree with that?
I'd agree with that. Yeah. I always said, one of my mentors said, it's like, we don't fix patients. We show the patients the way to fix themselves.
That's right.
Yeah. We get the patient back there. And even if it's a surgeon, it's like, granted, if the bone's sticking out, they go in there and they repair that. They repair that.
Right.
But at the same time, the body still needs to heal itself. Right. If the body didn't have a healing mechanism, then they would just, put that on there, and then I guess you could duct tape it or something. But
I had a friend of mine who said it this way, and he's religious, and he said, I do the cutting, God does the healing. So that he provides the environment and gets things back together where they need to be. But then the body's got to do its own thing. If the vascular system doesn't improve, the neural system doesn't improve, the skeletal system, the muscular system doesn't improve, then the body just won't heal itself correctly. So we're just facilitating what the body can naturally do on its own.
Absolutely.
We are definitely facilitators in that process.
Yeah, absolutely. I think the same thing holds true for coaching. Ultimately, I want the athletes in our gym to be able to squat a set of 5 and then self-diagnose problems that happen and then fix them. Yeah. If I did my job as a coach correctly, then they're going to see that rep 3. It's like, oh man, I got a little bit in my heels there. Let me fix that real quick. And without me having to say it.
Dr. Clearfield, you're not as familiar with what we do here at our gym, but Trent and I are barbell coaches, but we're also just fitness coaches in what we do. But we use the barbell a lot for developing strength and resistance training in our client population. And so we do that from all the way down to very young of age to we've had clients that are in their 80s in here. I've got a 67-year-old female client in here. I've got an 80-year-old client. And so we use a real simple approach, but it's very science-based, very logic and reason and human physics-based. And what I find, again, is that sometimes the simplest approach, most accurately targeted at the right area, provides great results, very powerful results. And that's kind of what you do in a lot of ways. A lot of what you do is very technical, but you've obviously become very skilled at it. And when you apply that right technique at the right place at the right time, along with education, and then also making sure that the diagnostics of your procedure are very accurate, you get great results. You get great results with the patient. So anything else we want to add today?
No, I think it's great. Thanks so much for joining us. This is fantastic.
Yeah,
This is a good
I've
conversation.
really enjoyed the conversation and everything. And this is fantastic.
We might have to have you on as a regular.
I was about to say,
come on
I
and
have so
talk
many
about
more
things.
questions I want to
I love
ask.
to hear
Yes.
myself
Yeah.
talk. So
It'd be fantastic. Yeah.
We'll make sure we cut out all the bad stuff from my end. And sometimes we say things and we just can't say them on the air.
yeah, no,
And sometimes they're actually really good snippets or memes. So
Yeah.
we use those things too. You know, there's, I was on a podcast quite a while ago and I said to the two guys I was on the podcast with, I was talking about joint health, and I said, you know what, guys, lubrication is everything. And they use that for everything. It would say, lubrication is everything. It just came on and on and on. It's like, sometimes that's inappropriate too. But yeah, we loved having you on here, Doctor. And if you want to find out more information about Dr. Clearfield and Motion is Medicine Sports Medicine Clinic, you can go to where? Where can they find you at?
So our website is www.motionismedicinedfw.DallasFortWorth.com. So motionismedicinedfw.com. And our number is 817-900-3539.
Do you have a Facebook page or an Instagram page or anything like that?
Absolutely, yeah. We have you can search for Motion is Medicine, Sports Medicine on Facebook, on Instagram, on Twitter. We're available on all those social media sites as well.
Okay, great. And we'll follow and share your sites on our Instagram and Facebook page too when we launch this podcast. So
Great.
Thanks for being here.
Yeah, thank you for having me. This has been great.
You bet. And thanks for joining 40 Fit Radio today and the 40 Fit Nation. If you want to hook up with 40 Fit Radio, you can go to 40fit.com. You can also go to our Instagram, which is at 40 Fit Radio. Trent is at Marmalade Cream on Instagram. I am at Dr. Deaton. And we loved having you guys today. Now go out there and regenerate.